Bismillahirrahmanirrahim. My dear colleagues, my dear audience, I'm Dr. Ahmed Jaber Amara. I'm an assistant lecturer of cardiology, cardiovascular department, Faculty of Medicine, Manufia University. We'll start with the first video in the episode 1 of preoperative cardiac assessment in patients with non-cardiac surgery. This video 1 is under the title of stepwise approach for preoperative evaluation of patients undergoing non-cardiac surgery. Stepwise approach for preoperative evaluation. Before starting in this 7 stepwise approach, I have 3 introductory points. The first point is an important question which is when to consult a cardiologist in a cost-effective manner, and here is the answer from the guidelines. For patients undergoing low and or intermediate risk non-cardiac surgery, they may be class 2B recommendation referred by an anesthesiologist for cardiological evaluation. While for patients who undergo high risk non-cardiac surgery, there should be here is the role of a multidisciplinary expert team consists of an anesthesiologist, cardiologist, the surgeon, and ICU physician. So we will recognize in the coming slides how can we determine if the surgery is low, intermediate, or high risk. At this point, if the patient undergo low or intermediate risk non-cardiac surgery, then we can consult a cardiologist, while if the patient undergoing high risk non-cardiac surgery, here is the role for a multidisciplinary expert team. The second point is laparoscopy less risky? For example, if you tell the surgeon that his patient has a high risk, a high preoperative risk, then the surgeon tells you that we can do the surgery using a laparoscopy, and you sadly tell the surgeon that open surgery compared with laparoscopy didn't reduce the preoperative risk of cardiac complications. So the guidelines recommend that patients should undergo preoperative risk assessment independently of an open or laparoscopic surgical approach is adopted. Okay. And finally, the third introductory point will cover the question that we all ask ourselves. What is the benefit of preoperative risk evaluation or patient evaluation if the surgery is emergent or even urgent? If we have to do the surgery even if the patient has high risk, and here is the effect of preoperative evaluation on the decision of surgery. If the surgery is emergent surgery, then preoperative evaluation will not affect the course or results of the intervention, but its influence will be in the management immediately post-operatively. Okay. While if the surgery is urgent one, so it will not influence the decision to perform the surgery as you have to perform it, but it may influence the measures to be taken preoperatively to reduce the risk. Also, presence of high preoperative cardiac risk may guide to choose a conservative treatment or less invasive procedure in favor of open or more invasive ones. For example, if the patient has a critical ischemia and he is which is a high risk surgical procedure, and the patient has a high preoperative risk factors, then the surgeon or the vascular surgeon may decide to deal with this condition conservatively better than doing the revascularization. Okay, so let's start with the 7-step-wise approach for preoperative cardiac evaluation of patients undergoing non-cardiac surgery, as this is the most important in this whole episode. I'd like to see is previous all two columns of preoperative anesthetic report assessment with the under column list of required investigations and other needs for patients done by my dear colleagues in Minofia University, to be replaced with the new one stepwise approach consisted of the step 1, 2, 3, 4, 5, 6 and 7 approach. I hope after this video this will change. Okay, so let's start with this stepwise approach, and the step 1 is determining the urgency of the surgery, the timing of the surgery, and according to timing of the surgery it may be emergent, urgent, semi-urgent or elective one. Emergent surgery, it means that it is life or limb threatening if not operated within 6 hours, while urgent, it is life or limb threatened if not performed within 24 hours. Semi-urgent, it can be delayed for up to 1 to 6 weeks, and elective, the surgery can be delayed for up to 1 year. So the good practice statement for these types of surgeries is that for patients requiring emergency surgery, so proceed directly to the surgery. We recommend against delaying the surgery for preoperative cardiac risk assessment for any time. While if the surgery is urgent or semi-urgent, you will proceed to the next step only if the patient's history or physical examination suggests a potential undiagnosed severe obstructive intracardiac abnormality like severe mitral stenosis, severe aortic stenosis, HOCM, hypertrophic obstructive cardiomyopathy, or severe pulmonary hypertension or unstable cardiovascular condition, and soon we will recognize the 5 unstable cardiovascular conditions mentioned here. So if the patient will undergo urgent or semi-urgent surgery, we will only proceed to the next step if these conditions are present. If these conditions are not present, so proceed directly to the surgery. While if the patient will undergo elective non-cardiac surgery, which can be postponed for up to 1 year, so then we will need to proceed to the next step only if the patient is above 45 years of age or less than 44 years of age with non-significant cardiovascular disease. Only if the patient is above 45 years of age or less than 44 years of age with non-significant cardiovascular disease, the 5 ones I will mention sooner. Okay, so what is the next step? The next step is to search for active or unstable cardiac condition, and this is the 5 ones that you should memorize well. Unstable angina pectoris, recent myocardial infarction or residual myocardial ischemia, acute heart failure manifestation, significant cardiac arrhythmia, symptomatic valvular heart disease, and these are the 5. If one of these active cardiac conditions or unstable cardiac condition is present, then you should postpone the procedure. And a multidisciplinary team should discuss the treatment options and best management preoperatively, then proceed to surgery. If these unstable cardiac conditions are absent, then proceed to step 3. Step 3 is to determine the risk of surgical procedure. Is to determine what? The risk of surgical procedure. As surgery, every different types of surgeries confer a different preoperative cardiovascular risk, and we define the surgical procedures into three categories according to their risk of cardiovascular complications. A low risk with less than 1% incidence of 30-day cardiovascular death and myocardial infarction. Intermediate risk with 1 to 5% risk of 30-day cardiovascular death and myocardial infarction, and high risk with above or more than 5% incidence of 30-day cardiovascular death and myocardial infarction. You should memorize these three categories, as a lot of our decision will be based on the risk of the surgical procedure. So the low risk surgeries, this risk is determined by, before we will tell the items of each category, I'd like to tell you what is the pathophysiology of preoperative myocardial infarction or myocardial injury. To understand this you should understand that the surgery equals stress, systemic stress and tissue stress. So the surgical procedure will cause stress, will cause an imbalance between a thrombogenic and fibrinolytic systems of the body, favoring this thrombogenicity, so producing a state of hypercoagulability. It will induce it will decrease nitric oxide, producing vasospasm of the coronaries. It will induce vulnerability of the pre-existing atherosclerotic plaques, causing plaque rupture, thrombus formation, and acute coronary syndrome. Also, the stressful situation of the surgery will increase myocardial oxygen demand, producing a state of oxygen demand supply mismatch, producing a myocardial ischemia. According to the degree of the stress produced by each different types of surgery, here is the categories. The low risk surgeries, as you know, it is the superficial surgeries like breast surgery, dental procedures, thyroid surgery, the subcutaneous, the ophthalmic surgeries, asymptomatic carotid like carotid endarterectomy, minor gynecological and minor urological like TURB, and minor orthopedic surgeries. While intermediate risk surgeries is all intraperitoneal surgeries like splenectomy, cholecystectomy, hernia repair, the symptomatic carotid, the major gynecological, urological, and major orthopedic surgeries, head and neck surgeries, renal transplantation, and non-major intrathoracic surgeries, and also the closed angioplasty for peripheral artery disease and EVAR endovascular aneurysm repair. While open aortic and major vascular surgeries, open revascularization of peripheral artery disease are high risk surgeries, like amputation is high risk surgery. The major intrathoracic surgeries are high risk surgeries. Perforated viscous repair is a high risk surgery. Radical cystectomy is a high risk surgery. Lung or liver transplantation are high risk surgeries. So you should memorize well these three categories of risk of surgical procedures. Okay, so we determine the risk of the surgical procedure. If this risk is low, the category of low risk surgical procedures, then you should recommend a lifestyle modification, identify and treat the risk factors of the patient, and optimize the medical treatment. If the patient has a non-ischemic heart disease, then the patient should be on the optimal dose of beta blocker. If the patient has a heart failure or systolic dysfunction, then the patient should be under treatment of the optimal dose or maximal dose of ACE inhibitor. And if the patient will undergo vascular surgery, you should initiate statin therapy before proceeding to the surgery, while if it is intermediate or high risk surgical procedure, then comes the step 4, which is determining the functional capacity of the patient, what we call effort tolerance. And functional capacity of the patient are measured and expressed in the form of MET, metabolic equivalent, and each one MET equals basal metabolic rate of the patient. Functional capacity and METs of the patient can be measured objectively using stress testing like stress ECG, but also we can roughly and subjectively measure the functional capacity of the patient. How this? Just simply by asking the patient about some of his daily physical activities. And here is what is important for preoperative evaluation is that the cutoff for here is the 4 minutes. If the patient's functional capacity is less than 4 minutes, then he has a poor functional capacity. But if the patient's functional capacity is 4 or more minutes, then he has a good functional capacity. And simply you can ask for this by asking the patient if he can climb up 2 flights of stairs without shortness of breath or not. If yes, then the patient has a 4 or more minutes and good functional capacity. If no, then the patient's functional capacity is poor. So if the patient has a good, remember that here we have the patient who will undergo intermediate or high risk surgery. If his functional capacity is good, 4 or more minutes, then you should identify the risk factors and treat it, recommend with lifestyle modification and optimize the patient's medical therapy. Beta blocker if he is ischemic heart disease, ACE inhibitor if he has a systolic dysfunction, and statin therapy if he will undergo a vascular surgery. But if this patient who will undergo intermediate or high risk surgery has a poor functional capacity less than 4 minutes, then we should calculate then we should we will divide we will proceed we will divide the patient if he will undergo intermediate risk surgery or he will undergo high risk surgery. If he will undergo intermediate risk surgery, then you should do non-invasive, you should ask for non-invasive assessment investigatory tools like baseline ECG, which is a class 1 recommendation, and non-invasive testing using resting echocardiography and cardiac markers, or what we call biomarkers, and we will discuss this later in the coming slides, is to be maybe considered. While if the patient will undergo high risk surgery, so the patient undergo high risk surgery and he has a poor functional capacity, then we should calculate for this patient his clinical risk factors. And we calculate the clinical risk factors using clinical risk indices. So the guidelines recommend with class 1 recommendation to calculate the clinical risk indices for patients undergoing evaluation for preoperative risk stratification, and we have two models for preoperative clinical risk indices calculation. We have Lee risk index, which is revised cardiac risk index, and we have a NSQIP model, So the two models for calculation of the clinical risk indices are the revised cardiac risk index, what we call Lee under by the name of the scientist Lee index, and the American College of Surgeons NSQIP risk calculator. And we will speak a little bit about these two risk indices. The revised cardiac risk index or Lee index, it is a simplified and more easy to use index, consisted of just 6 predictors. We can memorize them well and easy. and it has a more predictive values. It can predict the post-operative myocardial infarction, pulmonary edema, ventricular fibrillation, cardiac arrest, and complete heart block. While the NSQIP risk calculator, it is more difficult. It consists of 21 items. We cannot memorize them, and it only predicts post-operative myocardial infarction and cardiac arrest. So I recommend using routinely the revised cardiac risk early index in your daily practice. Okay, so the revised cardiac risk index early index, 6 predictors are, you should memorize them well: history of ischemic heart disease, history of congestive heart failure, history of cerebrovascular disease, stroke or TIA, history of diabetes requiring insulin therapy, history of chronic kidney disease with creatinine above 2 milligram per deciliter, or the patient type of surgery patient undergoes suprainguinal vascular, I mean vascular surgery involving the aorta, or intraperitoneal surgeries or intrathoracic surgery. These are the 6 items of the Lee index or revised cardiac risk index. For whom we should calculate these risk indices, I repeat, this should be calculated for patients who will undergo high risk surgery with poor functional capacity less than 4 minutes. Okay. Fortunately, we can use our mobile using the QMax calculator application on the Play Store, or using the MD Plus Calc on the website to calculate simply the cardiac the Lee index. Simply we will answer for with yes or no for the 6 items, then the risk will be appear here. And also the NSQIP calculator, which these are the 21 items of the NSQIP risk index. You just answer for these questions and the risk will appear sooner, so it is easy to use using the new softwares. These 6 items compared with the 21 item of the NSQIP calculator. So you calculate the risk factors for the patient with high risk surgery. If the number of risk factors is less than or equal to 2, so if there is 2 or less risk factors of the 6 of the revised cardiac Lee index, so the patient, you need to do resting echocardiography and biomarkers for evaluating the LV function. It is a class 2B, then proceed to the surgery. But if the patient has 3 or more of the 6 risk factors, then you should proceed to step 7. Step 7 is doing a cardiac stress testing. Doing cardiac stress testing to evaluate the ischemic burden of this patient, either using dobutamine echo, stress echocardiography, stress maybe thallium scanning, stress cardiac MR, or stress PET scan to evaluate the burden of the ischemia. If the patient has a no or moderate stress induced ischemia, I mean ischemic burden less than 20%, then you can proceed to the surgery after lifestyle risk factor and optimal medical therapy management. But if the patient has extensive ischemia with ischemic burden identified by stress imaging modalities above 20%, then here's the most challenging case you can ever meet in your practice. This will depend on an individualized multidisciplinary approach and weighting the benefit of proceeding to the surgery against the potential risk and harm on the cardiac condition. And here we should proceed to step 7B, which is we can determine for how much time the surgery can be postponed. If it is only can be postponed for at least 2 weeks only, then we can do revascularization using balloon angioplasty. To understand, the problem here is that after coronary revascularization, the patient need to be on a dual antiplatelet depth therapy for certain period of time according to the done procedure. So and the patient cannot enter surgery or undergo surgery when he is on a dual antiplatelet due to the very high risk of bleeding. So according to the time the surgery can be postponed, we can choose the type of revascularization. If it can only postpone for 2 weeks, then we can do just balloon angioplasty where the patient need to take the depth therapy for only 2 weeks. Then we stop the B2Y12 inhibitor, clopidogrel or ticagrelol, and we wait against with or against risk of the measure risk of bleeding to see if the patient will enter on aspirin or he should stop aspirin if the risk of operative bleeding is very high. Then proceed to the surgery. If the surgery can be postponed for 1 month, for 4 weeks, then we can do revascularization using bare metal stent with the patient on dual antiplatelet therapy for 1 months. Then a patient can continue on aspirin only or stop it if risk of bleeding is very high and proceed to surgery. And if the surgery can be postponed for 6 to 12 months, then we can use the new generation drug-eluting stent for which is depth therapy is required for 6 months only, or the old generation one for which the depth therapy is required for 12 months. Then stop B2Y12 inhibitor, continue or discontinue aspirin according to bleeding risk and proceed to surgery, or the patient can do cabbage if it is required. So this is the 7-step-wise approach for management of preoperative assessment for patient who will undergo preoperative surgery. So to memorize and summarize what we have said, first of step 1, you will determine the timing of the surgery. It is emergent, urgent, semi-urgent or elective. Then step 2 will determine if there is active, if there are an active or unstable cardiac conditions, one of the 5 conditions that we have taught. Then we will determine the risk of surgical procedure. It is low, intermediate or high risk. Then we will determine the functional capacity of the patient who will undergo intermediate or high risk of surgical procedure. If the patient will undergo high risk surgery and has a poor functional capacity, then we should calculate the cardiac risk indices using Lee index or NSQIP calculator. And finally, if the patient has more than 3 clinical risk factors, he will undergo high risk surgery and has poor functional capacity. Here we should do non-invasive stress imaging modalities to determine the burden of ischemia. Here we need a multidisciplinary team decision. Here we should weigh the benefit of doing the surgery against the preoperative cardiac risk. Okay, so we should in our daily practice, when we evaluate the patient preoperatively, we should use this 7-step-wise approach rather than the old 2-column with a list of preoperative all investigations you can imagine, which makes the surgeons and the surgical and surgery residents get mean. Okay, and finally I'd like to tell you some hints about the biomarkers that I told you. We can do non-invasive imaging using resting ECG, biomarkers, resting echocardiography. As I told you, biomarkers, I mean cardiac troponin, and which reflects the ischemic burden, which is highly specific for the myocardia. We can measure the natriuretic peptides, BMP, and N-terminal pro-BMP. reflect to predict the pre-operative and late cardiac events in high-risk patients. But you should know that routine use of biomarkers pre-operatively for risk stratification to prevent cardiac events not recommended. It is only recommended in patients with high risk surgery undergoing major patient with high risk factors undergoing major or high risk cardiac surgery. And resting ECG, I'd like to start first that routine preoperative ECG is not recommended for patients who have no risk factors and scheduled for low risk surgery. We are a poor country, as our president Sisi says, so ECG equals money, and routine use of preoperative ECG is not recommended if the patient has no risk factors and scheduled for low risk surgery. But if the patient has more risk factors, and undergoes intermediate or high risk surgery, so it is class 1 to do ECG. If the patient have risk factors and he will undergo low risk surgery, it may be done. It is a class 2B. And if the patient has no risk factors, or the patient is above 65 years but will undergo intermediate risk surgery, ECG may be done. So ECG not routinely done for patients above 65 years of age. It is only done if the patient above 65 years of age will undergo intermediate risk surgery, the category column B, as we mentioned before. Okay. And resting echocardiography, also routine echocardiography not recommended in patients undergoing intermediate or low risk surgery. If the patient undergo low or intermediate risk surgery, it is not routinely recommended to do resting echocardiography, even if the patient's age is 70 or 80 or 90 or even 100. It is only may be considered class 2B in patients undergoing high risk surgery. And stress imaging, as I told you, it is done for patients with high risk surgery with poor functional capacity, has 3 or more clinical risk factors. It is class 1 recommendation. If the patient will undergo intermediate risk surgery, it is class 2B, and routine use of stress imaging modalities in patients undergo low risk surgery is not recommended at all. Okay. And finally, invasively preoperative coronary angiography. The indications for preoperative coronary angiography is the same as indications for coronary angiography in normal situations. If the patient has STEMI, it is class 1 recommendation. If the patient has non-STEMI, we can do it invasively. If the patient has unstable angina or stable ischemic coronary disease with unstabilized chest pain, Canadian score 3 or 4, it is class 1 recommendation. It is class 2B recommendation to do preoperative coronary angiography in stable cardiac patient, stable coronary artery disease, if the patient undergo non-urgent carotid endarterectomy, while routine use in stable patients under stable coronary artery disease patient undergo low risk surgery is not recommended at all. Okay, I hope that in this video I have covered and clarified the 7-stepwise approach for preoperative evaluation of patients undergoing non-cardiac surgery. I hope this video will change our daily practice actually on real life in our hospital, especially in Montefiore University Hospital, as in our hospital a lot of required investigations are asked while they are not required. A lot of time delay done with more fear, not which is unjustified. If we make this stepwise approach universal, we can work in a multidisciplinary team and the best of benefit given to our patient. If you find this video is helpful, you can help us by doing like and share for our page on the Facebook, Dr. Ahmed Imara Weekly Cardio Talk Shows. And next Saturday we is a video to end this episode, which is risk reduction strategies for patients undergoing non-cardiac surgery. So wait for this after you hear well the video one, and thank you very much.